then I like to invite my very dear friend and young dynamic leader in retina, Dr. Vipin Rana, to speak about economic challenges of anti-VEGFs in Indian scenario. And he'll be filling up for Colonel Raji today.
Good morning, everyone. As Sir said in his previous talk, that he used to think one injection is equal to 50,000, and which is equivalent to one iPad. So how a common man can afford this? So I'll be talking absolutely on this thing. Michelson introduced diffusible glycoprotein factor X in 1980, which showed angiogenic properties resulting in proliferation and increased permeability of the vascular endothelium. And decades later, this 40 kilodalton molecule was recognized as VEGF, which we all know is released in response to the hypoxia. And it is being released by the retinal endothelial cells, Muller cells, and the retinal pigment epithelium. And it leads to abnormal angiogenesis, which is seen in proliferative diabetic retinopathy, CNVM, CRVO, and ROP. And we all know that all these diseases, they require anti-VEGF for its control. So let's talk about the prevalence of various retinal disorders. So if we talk about the ocular diseases, so in population above 65 years, on estimation, by year 2025, approximately 1/3 of all these diseases will be the retinal diseases. And as such, there is increase in the number of ARMD patients, and which leads to burden in the current eye care infrastructure, and it leads to lowering the ability to perform the activities of daily living. It also hampers the direct costs like inpatient and the outpatient expenses and the work absence, and leads to loss of the productivity. So let's talk about the Indian scenario. In Indian scenario, if we talk about the early ARMD, we have approximately 16.37% of the patients, and in late ARMD, 2.32% in India, which leads to chronic clinical, economic, and social burden. So approximately 18 to 22% of the Indian population is below the poverty line, and India's per capita income is mere $720 as compared to the $47,740 of the United States. So the estimated 0.1 million patients of wet ARMD in India will be spending approximately 1.2 billion as drug costs only. And from where this cost will be covered? We all know that this cost will be covered either by the insurance companies or will be sponsored by the government agencies. So these injections are administered once a month, or a pro-rata protocol is used, where the frequency depends on the OCT findings, and the studies have shown the usefulness of treatment extent also. So the more frequent injection scenarios incurred the additional costs, and that leads to the increased burden on the government. So the additional patient benefits were substantially higher than those of the less frequent injection scenario, which results in higher societal value. So as per the studies, the management of ARMD patient costs 8 times more money. Now, the patients receiving intravitreal anti-VEGF are expected to be compliant and should follow up regularly to receive their next scheduled dose. But 51.54% patients were lost to follow-up as per one study. And what were the reasons to loss to follow-up? The reasons were non-affordability, treatment elsewhere, shift of residence, no improvement in vision, transport issues, health issues, and expired or not willing. So the limitations for the treatment are invasive treatment. So some patients, they might be scared of getting these injections. Multiple treatments for 2 to 3 years, that leads to the poor compliance, and obviously expensive and unaffordable in developing nations. Insurance regulatory and developmental authorities of India included intravitreal injections under insurance coverage. Also there are challenges in the implementation which do exist, and the annual cap for the injections. That is also there. The total number of injections. And if we talk about the cost-effective analysis in the brolucizumab versus aflibercept, the data which I'll be showing this has been taken from the Hawk and Harrier studies. So it is on the basis of the administration, on the basis of adverse events, and the disease monitoring. Now, the brolucizumab reduces the economic burden of the intravitreal injections. It is preferred by those who want less injections, and obviously the less injections reduces outpatient workload, and it also leads to the less waiting list. So in a nutshell, improved vision associated with anti-VEGF treatment may provide economic value to the patients and society. Choice of anti-VEGF depends upon patient affordability more than science. Almost every patient will require repeated injections. So look for affordable alternative compounds. Discuss with patient before starting the therapy. And potent longer-acting drugs are now available to us that promise even better outcomes with fewer injections. So to conclude, anti-VEGF treatment has generated billions in benefits to patients. Unmet need still remains, and the novel therapies with better efficacy, more durability benefits, or mechanisms that reduce discontinuation may lead to substantial benefits. The drug industry should review the entire pricing policy of these drugs in developing countries like India. Thank you.
Thank you so much, Dr. Vipin. Any questions for him? So this has been one of the very important aspects of treating patients who require anti-VEGF, that is the pharmacoeconomics. We have been speaking about these pharmacoeconomics at every forum, and I am thankful to Dr. Lalit Verma for taking up this matter, both from the society, and we have been doing our bit at the national level by approaching the ministry for allowing certain allowances when we are injecting these drugs. There are two ways we are addressing the issue. One is the way in cataract surgery, we get a reimbursement for cataract surgery through the National Program Control of Blindness if you are registered with them to a tune of about 700-800 rupees. So a similar allowance can be made for giving an intravitreal injection. The second thing we are targeting are tax holidays for the companies, Indian companies who are manufacturing these anti-VEGFs. And we are trying to talk with the major multinational players to set up their manufacturing at our country so that we can have a certain cost reduction. That being said, why we speak so much about brolucizumab is that the cost of the molecule has not been priced at a prohibitive rate. The durability of the drug has been proven, and in our experience, the halving of the dose has worked well. So effectively, there has not been a cost escalation, but a cost decrease when you compare this originator molecule to the biosimilars of ranibizumab which are available today. If there are any questions from the audience, we'd like to address them. If not, then I'll thank the AV team for excellent support and AIOS for giving. Oh, yes, we have a question. Yes, there are. The systemic contraindications remain the same as with other anti-VEGFs. If a patient has had stroke, then for next 3 months, they should not be injected. In a case of recent MI, again, for next 3 months, they should not be injected. In patients of ROP, we have still not tried this drug because the systemic absorption of this drug is believed to be much higher. We tried obtaining a CTRI for a trial of ROP, but we were denied on the same principle that our neonatologists believe that this amount of drug, when it will enter the bloodstream, how it will affect the growth of the child is not certain. In the same vein, it is not advocated for pregnant women, especially in their first and third trimester. Now, it's very interesting that we speak about the nephrological indications for avoiding this drug. So, very recently, if you see, especially from the Mumbai zone, there have been reports by our nephrologists that in few of the patients, when they were given anti-VEGFs, their CKD control worsened. But to mind you that these are reports from one particular zone as of today. So we do not have a clear-cut nephrological contraindication to the use of the drug. Yes, in future it might arise. You are very right that at present we are having report from the Mumbai zone and around about the contraindications in patients of CKD for using anti-VEGFs. So once again, I'd like to thank and close this session. Thank you, AIOS, for this opportunity.